Welcome to Chapter 19 of Microbiology. This chapter is much shorter than that of the immunology sections, which you may be relieved for. And in particular, I have a survey of gram-positive bacilli that you may encounter in the clinic. I begin first by doing an ode to the anthrax letters. The anthrax letters were sent out in 2001, so shortly after 9/11. And essentially, they were all the rage. It was terrifying. There were people who were afraid to go check their mail. I have had students who were actually forbidden to check their mail by their parents. You may be too young to actually even remember this, but it was really frightening. And essentially what was happening is a terrorist put anthrax or Bacillus anthracis endospores in envelopes and sent those out to various prominent offices across the country. As a consequence of this, there were 5 people who did indeed die, and I think a little over 20 who came down with a bacillus infection. And so when we think about these gram-positive bacilli, seriously, Bacillus anthracis was a big deal, but then we also have bacteria that are in this family that do not produce endospores. And then we have bacteria that are equally as prevalent, such as Mycobacterium tuberculosis, that is acid-fast. And so our big way of differentiating bacteria in the microbiology lab is using a gram stain. You can see here there are bacillus cells that have formed distinct long chains, and so these are bacillus in chains. And these bacilli are gram-positive, being purple. And then here's a gram stain of a bacteria who produces endospores. So you can see the vegetative cells, and then on the inside of these vegetative cells, you can see endospores. They don't pick up the dye quite as readily. And so as a consequence, we have this other type of stain called a spore stain. Spore stains will stain these spores green, and they do so because they apply heat. The staining process is done over a heat method, and any of the bacteria that do not have spores are the vegetative cells. And then for the acid-fast stain, you can see that the non-acid-fast bacteria were stained blue, and then the acid-fast bacteria shown here in the pink or the red. And again, this stain is differential for bacteria that have mycolic acids in their cell wall. And so it's pretty helpful in the lab if they take the time to do these acid-fast stains. It could really identify what type of bacteria a patient is dealing with and give much more effective indicators prior to antibiotic therapies. So gram-positive bacteria, broken down into spore formers or not, we'll talk about various Bacillus species, Clostridium species, Listeria monocytogenes, and then a couple Corynebacterium and Mycobacterium. Bacillus anthracis is naturally found in the soil, and so the soil is the normal reservoir for this bacteria. It can, of course, be disseminated through animals or those being wild or domestic, and so the vector for transmission of Bacillus anthracis most definitely could be wild animals or zoonotic in origin. Anthrax is not communicable, so even if a patient comes into the clinic and has Bacillus anthracis, you are not at risk. You are only at risk when you have direct contact with these spores. And so the spores must first find a portal of entry. And so if we think about those portals of entry, it gives us a really good clue of how Bacillus anthracis will cause infections. And so portals of entry are ways at which it can enter the body. And so the respiratory tract is most definitely an excellent choice, the GI tract, and then there'll be a few that may be a little surprising. So these endospores only develop under certain conditions, and in particular, the endospores are not going to develop in the body. They're going to go through the vegetative stage, and you can see that, of course, once they're in the body, they're going to be actively replicating, and so instead of being the endospore stage, they are in the vegetative cell stage. Unfortunately, during this vegetative cell stage, they're going to produce toxins, which is actually what causes our most severe illnesses. So the 4 types of anthrax are cutaneous. So if you have a break in the skin and you come in contact with, endospores, they enter through the skin, and then of course, then they cause localized damage. Pulmonary infection is when you inhale spores. This is actually the most severe form. There's gastrointestinal spores, so ingested spores that are taken in through contaminated food or water. And then most recently, I had to add injection because the outbreaks of Bacillus anthracis are now being picked up by injection users throughout Northern Europe. Another spore former that is of particular interest is Clostridium perfringens. Clostridium perfringens is found in soil, the intestines of animals, so contaminated food or poultry are typically how it's going to reach many of your patients. And so food poisoning is nearly 1 million cases per year from Clostridium perfringens. And this takes place because of what I would call trough eating. And I don't mean that offensively, but when you're eating from places where you have food in very, very large portions, such as hospitals, cafeterias, those sorts of places, then you end up having more likely chances of contamination because this food is kept warm for long periods of time. So Bacillus, this particular bacteria, Clostridium perfringens, will form endospores during this period of time in the body. And so this bacteria produces a toxin called an enterotoxin. The enterotoxin is specific for our enterocytes and does cause diarrhea. So Clostridium perfringens as a pathology can also cause, in addition to food poisoning, cause gangrene. So you can see here that Clostridium perfringens, once it's inside the body and it's in the muscle cells, the normal anaerobic conditions are actually very, very deadly. So even though this isn't highly invasive, the production of exotoxins cause a press and movement in these gas-filled areas. So you have a complete fermentation of this bacteria. Fermenting microbes tend to digest various carbohydrates. And so the carbohydrates that exist within our bodies result in the formation of gas. If you do a carbohydrate analysis in lab, you would see that the outcome is typically gas and acid production, neither of which are pleasant for wound infections. And so predisposing factors are necessary for you to have an infection such as gas gangrene. And so you have to have an open portal of entry, which is a surgical incision, a pretty severe fracture, diabetic ulcers, puncture wounds from, say, for example, a cat bite, and then you have that contaminated with the endospore. And then, of course, things like gunshot wounds. My brain always goes to gas gangrene and, of course, the Civil War. And so the Civil War, actually, we lost most of our people because of gangrene, because of the wounds. The gunshot wounds would cause a closed-off infection. Things like Clostridium perfringens found in the soil would be picked up on the dirty bullets and things like that. And so it would be closed off in the tissue, and so they would have to amputate on site. And on site, they don't have very good aseptic technique. And so, they were essentially doing surgeries in a tent, and we lost quite a few lives on both sides because of these therapeutic targets. And so Clostridium perfringens, when we think about prevention and treatment, the prevention and treatment of Clostridium perfringens is essentially maintaining the food if it's a food poisoning sort of issue. So we want to make sure that those foods are kept cold or refrigerated within 2 hours of exposure to heat. And so hot food needs to remain hot, and it needs to be at a temperature above 140, so pretty hot. And of course, when we take our foods from, take foods home, or if we make foods for meals throughout the week, it's always good to put these into shallow containers that allow the food to become cold within a quick period of time, and then we put those in the refrigerator quickly. So maintaining them at a replicated temperature is how the bacteria is able to continue to grow, reach an infectious dose within those foods. Small amounts of bacteria aren't at the infectious dose, and so they cause no harm. Gas gangrene, however, because this is a deep wound, we actually take some different techniques. So debridement, which is very common, is the scraping away of diseased tissue or necrotic tissue from the individual wound. But then patients are put into a hyperbaric oxygen therapy chamber. And so I would like you to reflect on why you would put a patient into a hyperbaric oxygen therapy. So while you're thinking about that, I'm going to take you back to this slide, and hopefully you'll find some information that could be helpful here. This bacteria requires anaerobic conditions. And so those anaerobic conditions are the reason that this bacteria can be treated with things like hyperbaric oxygen therapy. And so by using hyperbaric oxygen therapy, you can actually kill the bacteria without even opening up wounds or debriding this area, but you can actually push oxygen in through the body at higher atmospheric pressures and then provide a pretty effective treatment for patients suffering from gas gangrene in today's society. Clostridium tetani is the causative agent of tetanus. This is typically found in soil, or you can actually isolate it from the GI tracts of various animals. It does cause tetanus or lockjaw, which is a neuromuscular disease. And so, oddly enough, growing up, even at a very young age, I associated tetanus with that of a rusty nail. And I cannot tell you where this information came from. I have not necessarily had it debunked, but it is, because it's, I suppose, a part of soil. The soil, if someone were to, I guess, leave a house and have building supplies, the rusty nail has been exposed to dirt, and then you have a deep wound. But ultimately, when I don't know how many infections take place because of rusty nails, or even the prevalence of people who, happen to step on such rusty nails. But, it just, to me, it's something that kind of solidifies Clostridium tetani in my brain. And so here in the United States, we don't have a ton of cases. We rapidly, at least every 10 years, we recommend individuals get their tetanus shot. And so it's more common among geriatric patients or IV drug users or neonates. What do all of these have in common? All of these individuals are immunocompromised. And so the pathology of these spores, they typically go through an accidental puncture wound, aka here's my rusty nail. And, as a consequence of that deep wound, it is an anaerobic environment. And so I suppose the rusty nail provides that perfect environment where it's a sharp wound, it goes in, and then once the nail is pulled out, then the area actually closes off. You could probably consider this analogous to that of a cat bite. So the incisors of a cat, the reason cat wounds are so nasty and deadly is because once the incisor is pulled out, the wound tends to close back over. So it's much more difficult to clear out. And if you're sealing in an anaerobic bacteria, you're allowing that anaerobic bacteria to undergo vegetative growth and then, of course, release the toxins. And the toxin is the problem. So the tetanus toxin causes things like neonatal tetanus. So you can see that this baby is suffering from tetanus. All the muscles are completely constricted, which is really quite deadly. And so neonatal tetanus or tetanospasms are essentially paralyzing, and they can paralyze the body and paralyze that of the respiratory muscles. And so patients will potentially die from asphyxiation due to the failure to use the diaphragm muscles to breathe. And so the tetanospasm, this neurotoxin, is going to bind to our motor neurons. It's going to inhibit muscle contraction inhibition. So the muscles are going to remain contracted. Do not get this confused with the bacteria that we're going to talk about in 2 seconds, which causes flaccid paralysis. And so tetanospasms is a constant contraction. There's no inhibition. And so in this case, the neurotoxin is blocking the release or the relaxation of the muscle. And so our treatment for this is an antitoxin therapy. And so antitoxin therapy is pre-prepared antibodies that are going to neutralize the toxin. And so the rub is, however, this is going to neutralize the toxin that is free, but it does not neutralize the toxin that is bound. And so since it can't neutralize the toxin that is bound, you actually have to wait for your patient to naturally resolve any bound toxin and relax on their own. And so within the hospital, you're going to provide various antibiotics such as penicillin or tetracycline. Both of these antibiotics are cell wall inhibitors, and they act on peptidoglycan. And so, or at least penicillin works on the cell wall. Tetracycline works on ribosomes. And so these guys, in addition to muscle relaxants, are going to provide, at least palliative therapy and control of the bacillus and additional growth. Clostridium difficile. This was discussed in some regard in your first homework assignment. Clostridium difficile, as you should know by now, that it causes antibiotic-associated colitis. And, this is all due to the competition that normally exists within a healthy GI tract. And so here's a healthy GI tract. Here is a GI tract that is suffering from Clostridium difficile. And so lots of inflammation, very, very unfortunate and pretty unpleasant experience for your patients. And it's because of the prevalence of these enterotoxins causing damage to the intestines. You have ulcers, big cause of diarrhea in hospital settings, and it's now becoming increasing among a community-acquired diarrhea, just picking up contaminated sources that have Clostridium difficile on them and ingesting Clostridium difficile. So the best therapy for this really is fecal transplants. It's not as widespread because of the broad spectrum resistance to antibiotics. C. diff, to get rid of it, it's nasty business. So it's a lot of work to provide antibiotic therapies to get rid of C. diff because of the overall broad spectrum resistance. And then, of course, as you provide those broad spectrum therapies, you then are allowing the colonization of other microbes or other illnesses, and the gut is just not healthy. And so ideally and hopefully things like fecal transplants will become more mainstream, or, utilizing various pill or capsulated probiotics to repopulate the gut with a healthy microbial flora. Clostridium and botulism. So Clostridium botulinum, now this is when we're going to start talking about that flaccid paralysis that I mentioned earlier. So let's go back briefly. And so here we're talking about tetanospasms that are paralysis because it is a constant contraction. When we talk about botulism is flaccid paralysis, especially in infants. And so botulism is the intoxication of the spores through poor food processes or, examples such as honey. So it is recommended that you do not feed infants honey because of the potential prevalence of botulism spores within the honey. Normal immune systems are able to take care of this. We use botulism and the botulin toxin for lots of fun things like beauty supplies, so releasing and relaxing those muscles so that we no longer have crow's feet or wrinkles in the forehead. This bacteria allows only growth in anaerobic conditions, and so when it has these anaerobic conditions, such as when you do home canning and things like that, but possibly don't get your foods up to the proper temperature, this allows for both the spore germination and vegetative growth. And so once then you open that food at a later date, it could have potentially then reached an infectious dose and caused harm. But the causative agent of harm is botulin, and that botulin toxin will actually go to the neuromuscular junctions and will block the release of acetylcholine. And so acetylcholine is necessary for contraction at the neuromuscular junction. If you block acetylcholine, you then have flaccid paralysis. So symptoms that can take place as a consequence of infection with botulin toxin is that of double or blurred vision. You can have issues swallowing, and of course neuromuscular symptoms, which isn't terribly shocking. The biggest concern with botulin is both infant botulism and wound botulism. So infant botulism is when you have a baby who has the toxin that has germinated, has been released. You now have flaccid paralysis, which is absolutely terrifying. No mother wants to, or father for that matter, wants to have an infant who is completely unresponsive. And so that, of course, is why we don't give children under the age of 2 honey. And then wound botulism, and I find this very curious. So wound botulism is one of those things that, once the spore gets in the wound, it provides food poisoning symptoms. And so I think ultimately that's going to be a difficult one to diagnose, simply because, the patient's going to have nausea and vomiting, but, ultimately it's the cause of this anaerobic condition in this wound that's allowing the spores to continue causing food poisoning symptoms. And so the spore-forming microbes that we have discussed are Bacillus anthracis, Clostridium perfringens, Clostridium difficile, Clostridium tetani, and Clostridium botulinum. Ultimately, this is just a nice brief overview. Make sure that you do know the bacterial name, the disease that is caused, and some unique factors about it. So gram-positive non-spore formers, such as Listeria monocytogenes, offers a whole host of new world when it comes to infection. So Listeria monocytogenes actually was a component of a recent outbreak. So as I'm recording these lectures, it's 2015. Listeria monocytogenes was in Bluebell ice cream. Not cool. We don't want bacteria in our ice cream. Fortunately, the Bluebell ice cream was, after a small bit of reporting, no deaths whatsoever. But it was recalled, and we all know which Bluebell ice cream to chuck out of a refrigerator. But this Listeria monocytogenes, even though it's a non-spore former, he is a nasty beast. He can grow in the cold, he can grow in heat, he can grow in salt, pH extremes, and resist bile. And then once it gets in our bodies, this is an intracellular bacteria. So this bacteria is not going to colonize the surface of our enterocytes. It's actually going to go into our phagocytes. So those macrophages, neutrophils, it's going to go in there and it's going to hide out inside the cell, which then allows it to avoid the humoral immune response. The humoral immune response, just as a refresher, is that of antibodies made by plasma B cells. And so this bacteria, because it's hiding out in the cell, has to have those killer CD8 T cells come secrete perforin and granzyme to lyse the infected macrophages. And so if the process of antigen presentation does not take place, you would never get those CD8 T cells activated, and you never get rid of this really nasty, unpleasant infection. And so the epidemiology of this guy, he's the third leading cause of food poisoning death. There is a 20% death rate, which is pretty stinking high considering we live in a pretty industrialized nation. The reservoir for this is soil and water, animal intestines, so pretty much all foodborne microbes tend to go through this standard route. And so the disease that is caused is called listeriosis. Listeriosis is often contaminants of dairy products, as I just mentioned, the awesome dairy outbreak, and then poultry and meat. So there was the Bluebell outbreak, and I think there was another outbreak this last semester as I was teaching in soft cheeses and things like that. So if you go to the CDC, you click on outbreaks, you can look at all the recent outbreaks that have taken place. E. coli and Listeria tend to be common offenders on that awesome website. And so for most people, it's not a big deal. You have mild subclinical symptoms as long as you have a healthy immune system. However, if you are immunocompromised or a baby, then it can actually go into meningitis, so it affects the brain and the meninges. So Corynebacterium diphtheriae is found in healthy carriers. It's the causative agent of diphtheria, so at least the names are kind of easy for studying for your exam. And in most cases, this is taking place only in people who are not immunized, overly crowded, unsanitary conditions. We've taken pretty good care of getting rid of this out of the United States, but it is transmitted by respiratory droplets from carriers, and so you can have someone who doesn't even know they're sick, and then, of course, that causes actively infected individuals to now carry this infection. And so diphtheria is identified by a pseudomembrane formation. I'll show you this on a new slide. And so that pseudomembrane formation all through the tonsils can actually cause asphyxiation. And so the localized infection, as long as it retains itself in the upper respiratory tract, it's mostly sore throat, lymph nodes, all this good stuff. But really, the pseudomembrane, it's the risk of asphyxiating or not being able to properly breathe because your upper airways are closed off. The other major pathological toxin is that of the diphtherotoxin. Diphtherotoxin can target our heart, nerves, and so it can lead to systemic damage if left untreated. Mycobacterium. So our mycobacteria, this guy is the one that possesses mycolic acids, right? So this is a unique type of peptidoglycan in the cell wall. These mycolic acids allow us to do things called an acid-fast stain. The acid-fast stain was shown on the first slide. Believe it or not, Mycobacterium is not highly invasive. it grows really slow. And so kind of makes you feel guilty. It's like, oh, it grows really slow, but so why are we still dealing with this problem? And it's because it grows slow, but there's a lot that we don't know about these mycobacterium, especially Mycobacterium leprae. But first we'll talk about Mycobacterium tuberculosis. And so even though it grows very slow, the fact that it is transmitted through respiratory droplets allows a pretty rapid dissemination of this bacteria. And so it is a tubercle bacillus. You can see it kind of grown here. So this is a description of a tubercle. It has a few virulence factors such as cord factor. So cord factor is shown stained here around these white blood cells. This cord factor prevents the microbe from being broken down by macrophages. And the phagolysosome. The phagolysosome is a specialized organelle in the macrophage, so it's the lysosome inside that macrophage. And when it can't be broken down, then it's difficult to get rid of this intracellular bacteria. And so tuberculosis is really a pandemic problem. Nearly a third of the world is infected with Mycobacterium tuberculosis. Of that, we have about 15 million people in the U.S. that are infected. And we have a really, really high rate in our immigrant population. And so there's a lot of efforts to screen and provide proper care for immigrants as they come into the country. In some cases, they may be placed under quarantine until proper therapies are provided. And so this bacteria is pretty resistant, and it's transmitted through airborne droplets. So even though it grows slowly, outside of the body, it can withstand quite a lot. And it's going to cause more damage in people who already have other comorbidities. So they have, other lung damage. So if they have pulmonary issues such as they're smokers, or possibly they grew up where I did and they have black lung from working in coal mines, and this sort of thing allows then tuberculosis to manifest and be much more severe in these particular demographics of populations. And so primary tuberculosis is literally an infectious dose of only 10 cells, so it's pretty infectious. And the fact that it's transmitting 10 cells through respiratory droplets, that's pretty much, if you have TB and you are in a room with another person, you're most likely going to transmit that infection to them. And so if you have patients who have TB, I think you'll be wearing a full respirator as you go into their specific rooms. And you'll be limited on whether or not you see other patients during that patient's care. And so primary TB is when the macrophages they're harboring this intracellular bacteria. It's going to last for about 3 to 4 weeks, so about a month. And during this month, there's a formation of tubercles. So these tubercles can actually be seen on X-ray. And the tubercles are the same thing as a specified granuloma. So granuloma is literally the giant cells, and these various erythroid cells are trying to wall off the bacteria. So the bacteria is shown here in yellow. And so you can see that this entire area is shown in yellow, which my yellow highlighter is not really doing a great job showing you further. But yeah, so here we go. So you can see the cells on the outside of my highlighting area. And essentially these cells are walling off the bacteria and saying, nope, stay where you are. And so the formation of the tubercles are to isolate it, because the bacteria is intracellular. You find these intracellularly infected macrophages, and if you can't get rid of them fast enough, you consolidate them and wall the area off. And so as a consequence of that, if the patient does not recover naturally from primary tuberculosis, there's a risk of reactivation. Because essentially the body didn't get rid of the bacilli. The bacilli are still in the body. They're just kind of closed off in an abscess type structure. And so essentially those abscesses, while they're closed off, the bacteria can still replicate. And so the bacteria is replicating, the cells are getting bigger and bigger and bigger, and then they can expand and drain. And when they drain, they are now moving to secondary TB. At secondary TB, your patient's going to experience very violent coughing, bloody sputum. They're going to have weight loss. At this stage, it is nearly a 60% mortality rate if it remains untreated. So that's not good. So the reason that we are so big on doing the TB skin tests is to make sure that we are aware of TB or exposure to TB very quickly. Because, if you're looking back at only 10 cells transmits very, very fast. So extrapulmonary TB is when TB was not treated in the primary stage. It then starts to drain, and then eventually, if TB is still not treated, it's going to move out of the lungs. And so TB is notorious for causing focal infections. These bacilli will break off, will move to new sites of infection, such as your eye. The CDC has an entire section about TB, and you'll probably want to review the CDC's section and information for your homework. And so extrapulmonary TB has moved, of course, extrapulmonary out of the lung, and it's getting into things like our lymph nodes, kidneys. This is really bad news. And of course, as a consequence, the condition's pretty grave. And so how do we make sure that we are protecting ourselves? We do the MANTO test, which is the PPD, protein purified derivative. And so the PPD test, or the MANTO test, is a slight injection through the epidermis. If a patient has antibodies to the distinct tuberculin proteins, then there will be this specific wheel that will emerge. And so you can see here, this is the wheel. And so there's a certain quantity of elevation that has to take place for this to be positive, in category 1, 2, 3. And so specificity of how much, the wheel responds. So, you still have a small response often. And so the test must be read within that 48 to 72 hour window. The wheel, or what I'm calling is the wheel, is actually an induration. And that induration is measured by the clinician who probably gave you the PPD test in the first place. So diagnosis, I told you that primary TB will have tubercles. So you can see the tubercle shown here. I'll just kind of outline the bottom of the tubercle. So the lung area, because the alveoli sac should be filled with air, the lung area should be completely black on an x-ray. And so here you can see the consolidation of tissue as shown by the white area. And so this consolidation of tissue is the tubercles there in that patient's right lung. And then, of course, the in vivo or tuberculin test, we talked about the MANTO test on the previous slide. I just discussed x-rays. We could do acid fast staining. So if you were taking this as an on-ground course, or possibly you are taking this as an on-ground course, the acid fast bacilli essentially would be shown through the microscope. And then, of course, you would then isolate the bacteria. So we could go through the process of Koch's postulates. And in that case, you would isolate it, grow it in a lab, and then perform various biochemical tests to make sure that it is indeed the causative agent. Mycobacterium leprae. So this guy is not just associated in biblical times. He does still exist today. So leprosy, in some cases, even though it's very slow growing, it's not contagious from person to person. It is incredibly frightening. It's typically spread more so through things like armadillos. And ultimately, you're probably thinking, well, when am I going to encounter an armadillo? But people do. I was watching The Nightmare Inside Me. So if you get a kick out of this stuff, that's probably a highly dramatized version of micro that you might enjoy watching while taking this course. And so there was a kid on there who did have leprosy, and he was severely disfigured at the end of that. Not quite to this level, but he had some pretty gnarly scars on his legs and things like that. And so leprosy, depending on the type of leprosy, essentially it could be very, very disfiguring, or it could just be a surface level leprosy. And so when we think about leprosy, it is still here, right? So annual cases of leprosy shown here, it's 1,000 to 999. Let me change this color. Red's probably not the most accessible color for people. And so, you can see here, it's, 1,000, whoops, that's not good. Let's delete that, erase that. Okay. And so you can see that it's, the pink is 1,000 to 100 within the United States, but there are places where leprosy is really quite high. Brazil and India are notorious for high populations, and even though it's not very virulent, individuals are coming in contact with the source of infection. And so the infection, similar to the other bacteria that we've been talking about, does hide out in our macrophages. And when it hides out in the macrophages, it's reducing the rates of antigen presentation. So the rates at which the macrophages or other phagocytic cells show T cells the type of microbe that it needs to respond to. And so as a consequence of that, you get a slow or weakened T cell response. Or even the cytolytic CD8 T cells, they're not as robust at killing because they're not getting activated as effectively in the forefront. And so this bacteria causes, more of a long-term slow and steady growth. And the two forms are tuberculoid and lepromatous. And tuberculoid is the least severe. Tuberculoid leprosy is when the immune system has a very pro-inflammatory immune response. So essentially what's happening is the pro-inflammatory response activates the immune cells so that the bacteria cannot penetrate the epidermal layers very deeply. And so these are shallow lesions, superficial loss. In some cases, you have some proprioception, pain reception that is diminished because of the disease, versus lepromatous is much deeper. So this bacteria has a less inflammatory immune response. And so this disease, literally, it's just a draw of the cards. Everybody's immune system is different. The T cells will respond differently from person to person. And if you have a robust immune response, you'll have tuberculoid leprosy and have shallow lesions. If you have a kind of a slightly different altered response, you then result in lepromatous leprosy. And this has been studied in quite detail. And so, this is because the bacillus is going to go deeper into the body. And when it goes deeper, it's going to be able to penetrate those dermal tissues and cause the nodules and much more severe damage. And so this is the conclusion of this set of information. Is very quick, pretty straightforward. Just as you go through the information, make sure that you know the bacteria name, know the disease that is caused, and know what is unique about it. And so in the case of Mycobacterium leprae, it's an intracellular microbe. The disease that results is different based on the type of immune response. So tuberculoid means that it's going to be a less severe disease, superficial lesions, versus lepromatous, very deep lesions, that sort of thing. And then, of course, if you have questions, please do reach out.